Hello everyone. Today I will be presenting implementing clinical guidelines for antenatal gestational weight gain care using a novel best-worst scaling method to determine priority barriers. My name is Eva Farragher. I'm a PhD candidate with the University of Newcastle's School of Medicine and Public Health. To provide you with a bit of context firstly to this research, despite Institute of Medicine gestational weight gain guidelines, evidence-based national dietary and physical activity recommendations, and Australian and international clinical guidelines for pregnancy care, globally, 70% of women are still gaining either too much or not enough gestational weight according to the IOM recommendations. And the problem with this is that it increases the odds of many health risks to mother and baby, both during birthing and postnatally. This includes gestational diabetes, macrosomia, preterm birth, and caesarean delivery. And these risks occur independently of a woman's pre-pregnancy body mass index. So evidence shows that structured diet and physical activity interventions delivered by healthcare providers are positively associated with improved gestational weight outcomes. In Australia, the Department of Health's Clinical Practice Guidelines for Pregnancy Care recommends that antenatal care providers at every routine visit assess weight and monitor gestational weight gain, provide brief behavioural support for weight gain, diet and physical activity, and offer a referral to specialist services such as a dietitian for women who are gaining outside of the IOM recommended ranges. So what we know is, despite 70% of women gaining outside these recommended ranges, and most women considering that recommended care is acceptable and indeed expected, fewer than 10% of women are receiving this care during pregnancy. So, what is stopping antenatal care providers from providing this essential care to pregnant people? We already know of commonly reported barriers to care from previous qualitative and quantitative international studies on clinician barriers. Identified barriers include time limitations, poor or limited resources, and perceptions of such discussions being sensitive or difficult. However, these studies have been limited by small sample sizes, lack of theory-based frameworks, do not include all types of antenatal care provider, and do not inform of the level of relative importance of these barriers. So, why then investigate barriers to the provision of antenatal care for gestational weight gain using best-worst scaling? Well, best-worst scaling is a maximum difference scaling method and a type of discrete choice experiment in which a respondent is asked to indicate the least preferred item in a choice set, in addition to indicating the traditional most preferred item. In this way, it avoids the known weaknesses of rating and ranking scales while potentially generating additional information. Our research used the object BWS or case 1 type study to determine the relative importance of attributes, in our case, barriers to care. This example is the actual first scenario from our survey. Respondents were asked to imagine that they were at a follow-up antenatal appointment, and as part of the routine care, the recommendation was to measure the patient, Sarah's weight. They had to indicate which one of 3 options they considered most likely to be a barrier to providing this care and which one they would consider least likely to be a barrier. This is then repeated 3 more times in different combinations for a total of 4 different response sets. Essentially, the respondent chooses the relative best and worst 4 times. The study design was a cross-sectional survey of antenatal care providers conducted between December 2020 and November 2021, and the setting was all public maternity services and care providers working within various maternity care models within 3 sectors of the Hunter New England Local Health District in New South Wales, Australia. To be eligible, participants had to have provided antenatal care in the past 12 months, and we had a research assistant attend each service to administer the surveys across various days and shifts to capture as many staff as possible. Surveys were completed via a paper form or directly into REDCap and took about 10 to 15 minutes to complete. We based our 5 survey questions on scenarios on the 5 key behaviours comprising the guideline recommended care, which I outlined earlier. In terms of participation, a total of 134 from 219 eligible antenatal care providers completed this best-worst scaling survey. The majority, 72% of respondents across all sites, were midwives. In terms of results, by considering first the COM-B source of behaviour and theoretical domains framework, we were able to map to barriers behind, or behaviours, behind each barrier. The counting approach implemented by the support.bws statistical package in R was used to analyse the survey data. A best-worst score was calculated for each scenario to determine the most likely and least likely barriers. The results were stratified by location, sites 1, 2, and 3, as well as by profession, midwifery versus medical professionals. The mean best-worst score is therefore the average of all individual scores calculated separately for each site and each profession. These means are then ordered from most negative to most positive to produce a rank order of each barrier for each site and each profession. This graph represents the analysis of the barriers for that first key behaviour, weighing at follow-up appointment, for the 3 sites. If you can see the 0 horizontal axis, any mean best-worst score above 0 is positive or positively associated with a barrier, and any below is considered not a barrier. Larger values in either direction are more important, whereas mean best-worst scores around 0 indicate that it was neither considered to be a barrier or to be not a barrier. Other useful information, though, can be derived from differences in results across sites. So at a glance, we can determine that antenatal care providers from sites 1 and 3 considered the barrier of not a priority the most likely barrier to providing weighing at follow-up appointments. However, site 2 ranked not feeling comfortable providing this care above this as their most likely barrier. This process was repeated for all respondents according to professional group, midwifery staff versus medical staff, demonstrating professional-based differences. We then, of course, tabulated and graphed all 5 behaviours to quantify and compare site-based differences and professional-based differences. So what do we do with all these insights into site and profession-based differences now? Remember that in developing the survey, we mapped the barriers to sources of behaviour and TDF domains. By determining the order and strength of importance of barriers to each identified element of care and using a theoretical framework such as the TDF, we can then utilise behavioural change techniques, or BCTs, to develop very targeted implementation strategies for each clinical setting and each professional group. In summary, the use of best-worst scaling therefore allows us to gauge not only the most frequently reported barriers, but their relative strength or importance when compared to other barriers. And by analysing the mean best-worst scores when stratified for criteria such as location or profession, we have salient information to design tailored implementation strategies to meet the needs of those specific locations and providers of care. And ultimately, better theory-based targeted strategies, when implemented and evaluated, will lead to better antenatal care for all women. Thank you so much.